Cyanosis is your friend. Seriously, cyanosis is instant feedback that your patient is likely deteriorating. Take two toddlers, both with the same hypoxic condition. One is cyanotic, and the other just looks a bit pale. Whom do you attend to quickly? Well, the blue one, right? But would you be surprised to learn that the other one, the one who just looks a little pale and tired, is just as sick, or maybe sicker? I think you may already know why, or do you? Stick around and find out.
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. Okay, I'm not trying to be tricky here. Both toddlers have terrible pneumonia. Both have retractions and nasal flaring and head bobbing. Both are hypoxic. Let's even say both are equally hypoxic. You slap on the pulse ox monitor and they both register at 86%. But only one is obviously hypoxic, the blue one. He has purple lips and an ashen blue appearance on his face and trunk. The other just looks wilted. Why? Well, cyanosis, that blue discoloration we get when hypoxic, only happens given certain conditions. The well-oxygenated hemoglobin molecule gives arterial blood that beautiful crimson red color that warms our hearts as clinicians. This means that the body is getting what it needs. The hemoglobin molecule is recruiting oxygen to bind to the iron moieties just enough to carry it and deliver it so easily to the tissues. Poorly oxygenated hemoglobin molecules show the other side of the iron color spectrum, blue. So, with a normal hematocrit, everything else being equal, oxygen is traveling across those beautiful, billowy, open alveoli. You look good, feel good, and are decidedly not hypoxic. If this person gets a terrible pneumonia and is unable to participate effectively in gas exchange, the proportion of poorly oxygenated to oxygenated hemoglobin molecules rises. That is, there's more deoxygenated hemoglobin in your RBCs than usual, and you go from a nice normal complexion with red blood perfusing your skin to a bluer, more purple, more deoxygenated supply chain. And we notice. Okay, so far so good. Nothing mind-blowing here. But what if I were to tell you that you could be very hypoxic, but just not show it? It turns out, even if you have a large proportion of poorly oxygenated blood, you may not notice until you have enough of it. That is, the proportion has to be just right. Cyanosis is just the end result when it's totally obvious that a good total amount of your hemoglobin is, well, blue. Then so are you. I'll explain. Our human eyes can only perceive so much. It turns out you need at least 5 grams per deciliter of poorly oxygenated blood to even see cyanosis. So, if your hemoglobin is a nice, robust 15 grams per deciliter, and you're unlucky enough to get the pneumonia, your gas exchange takes a hit. And proportionately, you have, say, 10 grams per deciliter of really great oxygenated blood, but now creeping up to about 5 grams per deciliter is mixed in this poorly oxygenated blood, and you end up looking kind of blue. Now, that's quite a proportion, and really a late sign. You've seen many people who are hypoxic, let's say with a saturation less than 90%, who weren't quite blue yet. That's probably because you caught it in time. You did some pretty good preemptive medicine, or you were just generally on your game that day. Or it was a fake out. What if you're anemic? What if your hemoglobin, total hemoglobin, is only 7 or 8 grams per deciliter? If it takes a total of at least 5 grams per deciliter of poorly oxygenated blood for our eyes to even see the cyanosis, wow, that now is a huge proportion of that person's blood. The more severe your anemia, the less likely you'll be able to show anyone cyanosis. But you're still hypoxic, very hypoxic, and arguably worse off because your total boxcars that deliver oxygen to the tissues are in short supply. And the scary thing is, you just might not see it, or at least recognize it for what it is. That patient may look more pale and tired to you, frankly more anemic looking to you, because there just isn't enough blood to show central cyanosis. This is another example, not only to understand the limits of cyanosis, don't expect it on everyone, but also to realize that pallor is just as concerning and may portend an even worse condition. What we just talked about was central cyanosis, a purplish or bluish discoloration of the skin or mucous membranes that's evident when the level of deoxygenated blood reaches a level perceptible to our human eyes. If we needed to hold on to a number, it usually starts at an oxygen saturation of about 85%. Peripheral cyanosis is a slightly different animal. Peripheral cyanosis shows up when the extremities are bluish or purplish. There isn't a global systemic problem with oxygenation. It's a problem with the circulation. Anytime there's sluggish movement through the capillaries, you may see peripheral cyanosis. So, elevated venous pressure, heart failure, venous obstruction, like in a blood clot, or vasomotor instability, or sepsis syndrome, or even vasoconstriction due to cold. There's a problem with extraction of the oxygen from the hemoglobin molecule to the tissues. The arterial side is supplying it well, but something happens at the tissue level. Perhaps the arterioles or the capillaries constrict because of cold. Perhaps the DVT causes venous congestion and slow venule transport. Peripheral cyanosis is, well, a problem with the periphery, with the capillary venous unit itself, and, of course, it carries its own differential diagnosis. We'll focus today on the life-threatening causes of central cyanosis and some fake-outs. You get a paramedic-based contact that they're bringing in a 2-year-old in severe distress. Mother found him gasping for air, blew around the face and chest, and they were too frantic to give you vital signs or further information. They'll be here in 5 minutes. What do? Rally the team. Of course, respiratory causes are the most common in children, but what about circulatory causes? Or maybe both. Could this child have a worsening pneumonia with now overwhelming sepsis syndrome? Whatever impaired oxygen exchange he's getting is now hindered by poor peripheral circulation, and the end organs take a hit. Who knows? Maybe this child's profound cyanosis is due to a decrease in inspired oxygen. We have no information. Was he in a building fire? Was there smoke inhalation? Are we ready to take over his sooty edematous airway? Incompletely combusted materials generate high levels of carbon monoxide. Maybe this is smoke inhalation, so less inspired oxygen at the gas exchange alveolar level, and carbon monoxide poisoning, causing inhibited oxygen recruitment at the level of the red blood cell. Or maybe some of that's true, but the plastics burning all around them in the house fire leach out cyanide, and now he has smoke inhalation, poor gas exchange at the alveoli, with carbon monoxide poisoning, poor oxygenation at the red blood cell level, and whatever little oxygen finally gets to the cells, the mitochondria are poisoned. Plus, he had a little touch of the pneumonia when the fire started, after he came back from an appointment with his cardiologist to check on how his bidirectional Glen shunt is doing. That is, after he took a huge bite of a hot dog. Okay, I'll stop now. The point I'm trying to make is that we really have to keep our differential diagnosis wide open when we see someone with cyanosis. Your best detective work will help you here, and there's no such thing as bad information. To recap, think respiratory causes like pneumonia, like airway foreign body, like bronchiolitis or life-threatening asthma. Is there stridor, so intranasal obstruction, or stridor, obstruction around the glottis? Do I need to do a few back blows or abdominal thrusts right now? Cardiac causes, such as any of the congenital heart diseases, or even acquired conditions like pulmonary hypertension, obesity or snoring, or a history of rheumatic heart disease. Feel for a left parasternal heave. Listen for a pathologic second heart sound, systolic or diastolic murmurs, and look for hepatomegaly and peripheral edema. Neurologic causes like meningoencephalitis, status epilepticus, or the long list of neuromuscular diseases. Is there a fever? What does your quick neurologic exam show you? Is this child chronically wasted? Speaking of other mechanical causes of cyanosis, what's the chest wall doing? Is there symmetric rise? Symmetric breath sounds? Do I see ecchymosis or abrasions on the chest wall? Grab the ultrasound machine. Do I need to put a chest tube in this child right now? Was there acute onset wheezing and respiratory distress? Maybe this is anaphylaxis. Or could this be due to a pre-existing intrinsic lung disease? Cystic fibrosis, bronchopulmonary dysplasia in the NICU graduate. Keep thinking common things are common, and just ask, could this just be terrible pneumonia? Maybe complicated with empyema. And finally, is this a type of metabolic poisoning? Carbon monoxide exposure, Methemoglobinemia, Sulfhemoglobinemia. Could this child have gotten into anyone's medications? Was he drinking well water? Anything. Now, this, of course, is not an exhaustive list, and I swear I haven't had too much coffee today. Although, is that even possible? Andy Tagg and I would beg to differ. Anyway, to quote someone who made it possible for you to have your grande latte healthy, hold the bacteria, le hasard ne favorise que les esprits préparés. Chance favors the prepared mind. All right, let's keep it real. A child in extremis arrives often alone and often without any information other than what you see in front of you, what you observe and hopefully ask and investigate. Keep your mind open and thinking about all of the various reasons that this child may be blue. So what do? You stabilize, treat for worst first, and quickly change course after you've made your intervention, reassessed, and realized it was something altogether different entirely. It's funny how we can get this particular condition so wrong initially. I think it's because of the urgency of the matter. The blue child comes to you and everyone's brain turns off and they stare at you for a course of action. It's only natural to anchor on the first thing that comes to mind, but make yourself think through the differential. Cyanosis is a great example of how sometimes we must go down multiple parallel paths until they converge or some just fall off and don't make sense anymore. Respiratory status? What's the circulatory status? Could it be a toxin? Here's the case. A nurse comes running back with a 4-day-old calling for help. He's blue. He's breathing very fast. He's listless. You position him, give him oxygen while you try to get some history. Born full term 4 days ago, family had scant prenatal care, but mother frantically blurts, "Everything was fine!" Until today, with increasing respiratory distress, just after the feed. When the baby started to look blue, she drove here. The child has a heart rate of 110, respiratory rate 70, oxygen saturation 78%, despite supplemental oxygen. What now? And what vital sign bothers you the most? There's a long answer and a short answer. The short answer is, give prostaglandin for a likely ductal-dependent lesion. Watch the child start to oxygenate better and better as the ductus arteriosus begins to reopen. You're likely going to need to intubate, especially since PG can cause apnea, but resuscitate first. It does open up that shunt, and it can save the child and give him a chance to make the diagnosis of cyanotic congenital heart disease and weigh the surgical options. That is probably the worst case scenario of cyanosis. The respiratory causes are usually pretty straightforward. The neurologic, not so much, but you usually have time to flesh those out. More to come on another playbook. We'll deep dive into the evaluation and stabilization of the newborn with a congenital heart disease. But for now, just know that PGE can be life-saving. Also, think infectious, toxic, metabolic, when that respiratory etiology just doesn't make sense. Here's another not-so-straightforward case. A 9-month-old is brought into triage because mom doesn't think he looks right, and she's worried about his breathing. You see the child, and he's crying, fussy, and, well, blue. His lips, hands, and fingernails are dark blue. He doesn't feel hot. His heart rate is 150. He's breathing at 32 breaths per minute with an oxygen saturation of 80%. You put oxygen on him while you're trying to do your rapid assessment. While you're trying to get some history, the mother understandably is very upset and you're just not getting very far. The non-rebreather is filling and collapsing with each breath. The infant's face is still blue behind it. It's times like this when you can't go through a full H&P and hope to come up with an answer. You need to ask directed questions. Here, what's the stimulus? What's the trigger? When you see a young child who was previously well and now critically ill, think trauma and toxins. Is anyone in the house on any medications? Has anyone visited recently? Has the child gotten any new medications or any over-the-counter medications or home remedies or supplements? You see where I'm going with this. But you have to try to do it in the least accusatory phrasing. Like, for example, this would not work. Could he have gotten into anything? What does the panicked parent hear? Are you a lazy and careless parent? Do your best to phrase your pointed questions in a way that helps you work together to try to troubleshoot together. Make the parent or caregiver your ally. Be transparent with your thinking and let them know that you're trying to figure this out in real time. Well, it turns out the baby has been teething and fussy. Mom was told whiskey should help. Okay, how much? And it turns out it really was just a few drops on the finger that she rubbed into the gums. After you reassure her that the whiskey did not cause this, she relaxes. Oh, she remembers. I had some old teething gel from my other child, and I did give him some of that. Okay, except it turns out so did Auntie and Uncle and anyone else who came to visit and rubbed this gel on him ad lib. Now what? Teething gels can contain benzocaine. What happens when we give too much benzocaine? I'll give you a hint. It's the same thing that happens when a gastroenterologist sprays half the can of hurricane spray down the throat for an endoscopy. Here's the deal. The iron in hemoglobin likes to be in the divalent ferrous state, Fe2+. That way, it's very efficient at picking up and dropping off oxygen molecules. We always have some oxidative stress to our red blood cells, and the beautifully efficient, lean and mean Fe2+ can get roughed up a little bit and maybe chewed up into the ferric version, Fe3+. This Fe3+ hemoglobin version is methemoglobin. A little bit here and there of methemoglobin is normal, and it's tolerated very nicely. Typically about 1 to 2% of our hemoglobin in even healthy people is methemoglobin. We can handle that. Our free radical scavenger, NADPH, are you really going to make me say it? Okay, nicotinamide adenine dinucleotide phosphate uses a cytochrome to reduce Fe3+ to Fe2+. And the world is a nice oxygenated place. Your body does this all of the time, and you don't even realize or appreciate it, do you? The trouble is, when there's more oxidative stress than there should be, when a new medicine or toxin overwhelms your normal maintenance program, you overwhelm the system. Fe3+ is getting generated right and left, but you've already spent all of your reduction money. What happens? Fe3+, the ferric iron, does a terrible job of picking up oxygen. So you get cellular asphyxia. No matter how much supplemental oxygen you give someone, they do get it in their lungs. There is some gas exchange to the alveoli, but there isn't any binding or transport on the red blood cells. And you end up with an emergency physician who is scratching his or her head trying to figure out why the blue baby is blue still on oxygen. That is, until you ask the right questions. What do? Remember that mantra? You give a blue patient a blue medicine, and they turn pink. That's right. Enter Methylene Blue. Let's take a little trip down history lane. Methylene blue, or methylthionine chloride, was a mistake. Or, that is, it became the right thing for the wrong reason. It was first synthesized in 1876 by Heinrich Karl, a German chemist who was working on a new, brilliantly blue dye for textiles and clothing. The jump to medicine happened when Robert Koch, a German microbiologist and physician, found it very useful to stain mycobacterium in the late 19th century. People were frantic to understand and control the spread of communicable diseases like TB at the time. The next jump happened when Nobel Prize winner Paul Ehrlich, who thought, hey, if we can stain parasites with methylene blue on the slide, maybe if we give it to the patient, it will stun them or harm them, and maybe we can actually use it as treatment. He wasn't totally far off. Methylene blue was still being investigated for use in infectious disease. Accidentally, we found out later that it had an effect on the oxidation and reduction balance of hemoglobin. It's a complex pathway, and honestly, I think we've nerded it out enough for one day. Let's just say electrons are donated, things happen, and the result is the restoration of Fe3+ to Fe2+ via NADPH, and that is plenty, my friend. We see a blue patient, and we give them 1 milligram per kilogram of a blue dye, methylene blue, and we donate electrons, and we get our hemoglobin working again, and the patient pinks up. We place a line, we draw some labs, we'll need a hemoglobin level, chemistries for our differential diagnosis, and also important, if you can get it, a venous blood gas with co-oximetry. The co-oximeter will likely tell you all of the odd and irregular and pathologic oxygen moieties, like carbon monoxide and methemoglobin. Although the real diagnosis is clinical, and with improvement with Methylene Blue, it'll be helpful to verify that that was the only thing that you need to worry about. The blood you draw is a characteristically chocolate brown. It's the color of rusted blood, really. That itself can nail the diagnosis. Then, Methylene Blue to the rescue. So, our 9-month-old goes from respiratory distress with clear lungs and an oxygen saturation of 78 to 80% to a comfortable but tired baby who is now pink and saturating at 96 to 98%. Whew. You would want to monitor the child and make sure to decontaminate if at all possible. In this case, the benzocaine was already absorbed. Rarely is there a rebound effect, but it's wise to spend a little time. In the adult, you would also think about whether this hypoxic stress has caused myocardial injury, for example. Methemoglobinemia can be caused by anything that oxidizes your hemoglobin. There are some congenital causes, but those are rare. Usually it's due to a long list of meds and chemicals. Here are a few to watch out for. Remember any of the canes: benzocaine, lidocaine, prilocaine, and while we're at it, cocaine. Dapsone is a drug that's used for tuberculosis, pneumocystis, ITP, and various chronic skin diseases. Grandma is visiting and she takes something for her TB? If that grandbaby is blue, think methemoglobinemia. Antimalarials, antihypertensives, especially any of those that contain nitrates, antipsychotics, all of them can cause methemoglobinemia, and the list is just too long to memorize. The point is, drug, chemical, or occupational exposure in a Smurf? Methylene Blue, 1 to 2 milligrams per kilogram based on lean body weight over 5 to 10 minutes. Many people, including me, we think to give 1 milligram per kilogram of lean body weight over 5 minutes, and then we have the option to repeat once if we need to. The max dose is not a quantitative level, it's based on lean body weight. Max 24-hour dosing is 2 milligrams per kilogram. So if you give the initial 1 milligram per kilogram first, because it's usually very sufficient in treating the methemoglobinemia and it confirms the diagnosis, that's plenty to give you what you need and to treat the patient. If hours later there's rebound, by just giving the 1 milligram per kilogram initially, it gives you the opportunity for you or even your colleagues later on to give that extra 1 milligram per kilogram to treat again without going over the 24-hour max. Look out for side effects that can be concerning to the patient, including flushing or headache or dizziness, nausea, and hypertension. Don't be fooled. You're doing the right thing. All of those are to be expected. All right, you got this. Right? But, okay, what if I told you there's one more thing to think about? Sulfhemoglobinemia. Luckily, this is much rarer, but it's definitely much more concerning. Sulfhemoglobinemia is a true cellular poisoning. A sulfur atom is irreversibly incorporated into the hemoglobin molecule. This disrupts the whole molecule from accepting and delivering oxygen molecules. The problem is, there is no antidote. You'll see a patient that you think is a methemoglobinemia case. Except instead of an obvious bluish purple cyanosis, he may look more greenish blue. You give oxygen, no help. You give methylene blue because it's the right thing to do, and no help. Your co-ox shows normal methemoglobin levels, but shows elevated sulfhemoglobin, which should never, ever really happen. The only treatment for this is supportive. You can do an exchange transfusion of red blood cells, and that might be the only thing that helps you get out of this hypoxic state. An overdose of any sulfa-containing medications can cause it. Here are a few rapid-fire biz-buzz quiz scenarios. Mother has migraines and teenager overdoses on her medication, and now she's bluish-green and hypoxic. Sumatriptan overdose. Someone has a urinary tract infection in the family, and the toddler gets into the med, turns greenish-blue and hypoxic. Peridium. You would likely register this in your head as Methemoglobinemia, but if you're a baller, you'll see that after the O2, after the Methylene Blue, no change, and yeah, that actually is a little more greenish blue. Get that patient an exchange transfusion for Sulfhemoglobinemia. Okay, that was a lot of brain work we just did. Let's talk about a few more lighthearted, less intense causes of blue patients. Acrocyanosis, the bluish-purplish discoloration of the hands and feet, it's a vasoconstriction phenomenon, usually in smaller children and usually due to cold. The child's body is trying to preserve heat by shunting blood to the core rather than allowing more radiation of heat in the extremities. Basically, warm them up. If that doesn't do it, think about why the systemic vascular resistance is still high. Could this be early sepsis? Okay, what about cyanosis just around the lips? Well, it depends. Assume hypooxygenation, but it's an important little tidbit to know that healthy infants can get this when they feed, usually when they breastfeed. They get this because the face is very well perfused, and there is sometimes a bit of venous congestion when the very vascularized lips are pressed against the breast or the latex nipple. Mothers may come in worried and report this to you, or you may observe this when the child is feeding in the ED. And we do have to think a bit, since infants less than 6 months of age are obligate nasal breathers. If they're obstructed, then there may be some respiratory distress with feeds, and maybe cyanosis? This almost never happens. Babies are smarter than that. They will fuss and just not feed. When you have to decide between breathing and eating, of course, breathing comes first. So here's how you tell the difference. The well-appearing infant who is thriving, is feeding, has a little purplish venous plexus congestion because of the feed, which may also linger for a few minutes. Your question, is this early central cyanosis? Well, if he looks good and his tongue is pink, you're in great shape. Just a little reassurance is all that's needed. Okay, I can't leave you without a few weirdo cases. Like new blue jeans. This happens not infrequently enough to mention. Suddenly, this very well-appearing, often teenage patient frantically comes in with blue legs. An alcohol pad or so later, and we have the diagnosis and treatment. Same goes for blue or purple popsicles or those super sweet sugary drinks. Yep, food coloring. Everybody, take a breath. Then there are the sadder cases. People turn to homeopathy or alternative methods for all kinds of reasons. Colloidal silver is touted as a cure-all, and it's natural. Too much of that, and you develop argyria, a bluish-gray pigment to your skin. Unfortunately, I've seen some terminally ill children whose parents bring them in for just that reason, and they were doing their best to try to cure their child of an incurable disease. A little education may help. We mentioned that exposure to cold can cause acrocyanosis, an intense peripheral vasoconstriction that can look like septic shock when they first come in, purplish and cold. Remember, warm them up, and that's your diagnosis in the well child. Similarly, babies can get an intense cutis marmorata, marbled skin, really all over their body, even when they're undressed in a cool room. Just a few minutes of swaddling this well-appearing infant will give you the answer and the treatment. In summary, cyanosis can be caused by a whole range of disorders. Think respiratory first and impending cardiopulmonary arrest. Open the airway, position the child. If choking is at all on your differential, for a child less than 1 year of age, do 5 back blows and, if needed, 5 chest thrusts. Reassess the airway, repeat as needed. For children older than 1 year, do abdominal thrusts. Get ready to do ALS maneuvers and use your laryngoscope with McGill's to remove that foreign body. Otherwise, position and oxygen, better, the same. Keep your differential diagnosis broad. Be the detective. Try things even if you're unsure. Remember, respiratory, cardiac, neurologic, infectious, traumatic, metabolic, and toxic. Now that I've sufficiently scared you, it's okay. I know that you're going to do the right thing when the time comes. Chance does favor the prepared mind. So, until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.